You can hear me okay? Okay. So thanks for that very kind introduction. What I'd like to do in the next 10 to 15 minutes or so is review with you some of the more recent advances in the treatment of women with breast cancer, as well as those who are at increased risk for developing this disease. At the end, what I'd like to focus on is some of where I think we might be going over the next 5 years or so when we think about the treatment of women with breast cancer. So I was asked before I start to give you a little bit of background about myself and how I got here. And you heard already, and you probably would have figured it out pretty quickly, that I'm Canadian. I was born and raised in Montreal, and I did most of my education and training there. I was not one of these people who, as a 6-year-old, knew I wanted to be a doctor. I actually knew I was interested in science, and I really thought that what I would do with my life is go on to get a graduate degree, get a PhD, and work in a basic science research lab. And that's how I approached my undergraduate education. As a parenthesis, it's a lot more fun to be an undergrad who's thinking about science than pre-med. So I really enjoyed my undergrad a lot more than my pre-med colleagues. But partway along the road, I got some advice that maybe doing medicine would be a smarter way to do this. If I really wanted to do something that could have an impact in the lab, maybe I should learn more about the disease itself and learn through my medical education, and then come back to a lab and be a basic scientist who had the education and the understanding of what it meant in the clinic, in the practical space. So that's how I went to medical school. I went to medical school thinking that that's what I would do with my medical education. And that premise held true for me for the first year or so, until the second year of medical school, when I ended up for the very first time in clinic. And that changed everything for me. For me, once I had my first patient care experience, that's where I knew I wanted to be. I wanted to be able to take some of what I understood about science, but translate it and offer it to the person who was in front of me, and to hopefully help guide somebody through a difficult diagnosis. And as I made my way through my medical residency and eventually to oncology, there was no better place than that for me to take what I understood and what I was continuing to learn about the treatment and understanding of this disease, but hopefully bring it down to a personal level and recognize, as doctors, what we know and what we recognize is we're not treating an illness, right? We're treating a person. And we're treating that person who is surrounded by family and loved ones. And that it's very important, obviously, to recommend appropriate treatment, but to do it in the context of treating the whole person. So I was fortunate after my residency and my training in Montreal to be offered a third year, a year of breast cancer fellowship at Georgetown's Lombardi. And then I was very fortunate after that year to be offered a faculty position. And I've been there ever since for more years than I would like to admit. I have been in this city, and I've been at Georgetown. And I think some of you in the audience know about Lombardi. You have connections to it. But let me just take a minute or two to tell you a little bit about Lombardi and what it is. Lombardi is one of the 47 NCI-designated comprehensive cancer centers. And what does that mean? That means that I have the luxury of working in an environment that has tremendous depth and breadth. I work not only with a lot of other clinicians who are really focused solely on the care of breast cancer patients. And when I say lots of other clinicians, what do I mean? People like me, medical oncologists, but surgeons and radiation oncologists and plastic surgeons and breast imagers and pathologists and lots of other behind-the-scenes people who are really involved in the care, solely in the care of breast cancer patients or women at risk for this disease. And at Lombardi, in order to be a comprehensive cancer center, you not only have to have the clinical expertise that has as a strong focus research, you also have to have a lot of interdisciplinary work with basic scientists who are trying to help us figure out the underpinnings of the disease and how we could really shift the outcome for women by better understanding what's going on, and also behavioral or population scientists who help us translate that into the community. So that's some of where I am and where I have been. So what I'd like to do now is try to talk to you about some of the advances in breast cancer over the 20 plus years that I've had the opportunity to be in this field. And it actually was quite a daunting task. When I finally sat down to really think about what I was going to say today, I became quickly overwhelmed. And what I realized is that there have been so many advances in breast cancer, and we have made so much progress since when I first started, that I couldn't possibly spend the time telling you everything about where we have gotten and what we have done to get to where we are today. So the overarching principle on this is that for a woman who's diagnosed with breast cancer today in this country, her outlook is so much better than it used to be, even 10 years ago or 15 years ago or 20 years ago. And that's really because of advances that we've made in understanding the treatment of this disease predominantly, as well as advances in screening for this disease. So what I thought I would do is give you some examples from different areas. I've already alluded to the fact that I work within a small village, right? A community of clinicians who are involved in the care of cancer patients. So I thought I'd give you little examples from different of those areas to give you a sense of things. So if we think about breast cancer, and just to give you just some general overview of this, we really think about breast cancer as early stage disease, where we're really trying to increase the chance of cure for the disease that's confined to the breast or the lymph nodes on the same side. And then there's metastatic disease or advanced disease. And in the early stage setting, I think many of you have heard about the surgical treatment of early stage breast cancer, which is typically something like lumpectomy or mastectomy. And what has happened over the years has really been a reduction in the type of surgery that gets done, so as we're minimizing the toxicities of the surgery. So when I started, women with early stage breast cancer all had virtually all of the lymph nodes underneath their arm removed at the time of diagnosis. And that led to risks of arm swelling that have obvious consequences. And what has happened through a series of well-done clinical trials, what has become apparent is that you don't have to take out all the lymph nodes. You just have to identify the first node or the first set of nodes that would be the initial ones that would drain. If there was a cancer, they'd be the initial ones that the cancer would go to. And that's called a sentinel node procedure. So it's sort of like the sentinel soldier, the scout soldier that you send out to look. If you identify that and that's negative, you're done. And what you can do is you can minimize the toxicity and the risks associated with taking out all of the lymph nodes. Similarly, my plastic surgery colleagues, cosmesis is just, advances at warp speed. What they can do in terms of reconstructive surgery these days for women who have mastectomies is just drastically different from what they were able to do even a few years ago. So the cosmetic outcome for somebody who has a mastectomy and who has reconstruction for breast cancer is so much better because of the advances in the techniques. My radiation oncology colleagues are getting better and better at minimizing other areas of exposure, so they're really narrowing down their field of radiation, and they're being able to plan in a more focused way, and thereby also diminish the risks from the radiation. In terms of what I do as a medical oncologist, I'm the one who makes recommendations for systemic treatment to reduce the risk of the cancer coming back, and that's where chemotherapy comes in, or endocrine therapy, or targeted therapy. And really, again, in this field, we've seen these incredible advances over the past number of years. And if I thought of how I could distill that down for you, what we're really getting to in medicine, and this is true for breast cancer, but honestly it's true for most areas in cancer or in medicine in general, what we're trying to do is get more personalized, more tailored, more individualized in our treatment recommendations. So what we're trying to do, really most basically, is find the right drug for the right person. The converse of that is not exposing people who don't need it to those drugs as well. So the advances that have been made have really been along two parallel paths: new drugs being developed and identification of new targets that we could potentially, so that the drug developers could develop drugs that target those specific areas. And I'll give you a couple of examples here. So there is a subtype of breast cancer. When I first started, it was the most aggressive subtype. It was a subtype known as HER2 positive breast cancer. So breast cancer gets divided into different subtypes, and some of you might have friends or might have gone through it or might know somebody, so this lingo might be familiar. But this HER2 positive breast cancer, what is it? What is HER2? HER2 is a protein. It's present in excess amounts in about 15 to 20% of breast cancers. What is it? It's a receptor. So it's sort of like something sitting on the surface of the cell. You can think of it like a television antenna, waiting for something to bind to it, to turn it on. You don't want cancer cells turned on, right? You want them turned off, okay? So it became apparent when HER2 was identified as a very important driver for that subtype of breast cancer. What became apparent is it would be really great to figure out something to turn that off. So when I first started, we didn't have that something. And subsequently what happened is that drugs were developed that targeted HER2 and were able to turn it off. And what large randomized clinical trials showed was that women who got that drug, and that drug's called Herceptin, it's been around now for a decade and a half or 2 decades, That drug, when you added it to standard chemotherapy, markedly changed the outcome for women who had that subtype of breast cancer. More recently, another drug, another antibody that targets a different part of HER2 has been identified, has been tested in clinical trials that we and others have participated in, has been shown to add over and above what Herceptin did. And so now the outlook for women with HER2-positive breast cancer is actually excellent. And I just had a patient who was really not sure that she wanted treatment, and I had to remind her that in the absence of the incredible therapies that we have available, the risk of recurrence is enormously high, but that is dramatically different when you have these therapies at hand. The other area that we can think of when we're thinking about that is how can we minimize treatment? How can we avoid treatment in people who don't need it? So there have been a series of assays or tests that have been developed that allow us to figure out which women in a certain subset of breast cancer can avoid chemotherapy entirely. So turn the clock back again 10 plus years, we used to give chemotherapy to huge swaths of women when we knew that we were only benefiting a few, but we weren't smart enough to be able to figure out who those few were. And this assay that got developed and validated and had to be proven to us that it was actually useful and we could trust it, now changes things dramatically. We send this off on the tumor specimen of all people who have that subtype of breast cancer to try and figure out whether that woman is a woman who actually will be the one who would benefit from chemotherapy based on the characteristics of her tumor, as compared to the one who could avoid it. And so those things have allowed us to get more tailored and more personalized in our approaches. The final area that I just want to highlight as we think about this has to do with the genetics of breast cancer. I think many of you have heard a lot about this, right? We've all heard Angelina Jolie's story, right? And Angelina Jolie her mom had ovarian cancer, and she was found to carry a BRCA1 mutation. And what we know is that individuals who have a BRCA1 or BRCA2 mutation have a markedly elevated risk of developing both early onset breast cancer and early onset ovarian cancer. So it was about 2 decades ago that those genes were identified, and it became possible to offer genetic testing to women who came from these high-risk families. At the time, we started our genetics program at Georgetown Lombardi, and we really helped and were part of an international effort that helped to characterize what it meant to have a BRCA1 or BRCA2 mutation. So at the beginning, what it felt like was that you just had a crystal ball, right? And you just sat in front of somebody and said, look, I'm really sorry. You have a mutation in BRCA1, so you have a really high risk of developing breast or ovarian cancer. There are things that we think we can do to help mitigate those risks, but we don't have evidence. And in medicine, you really have to have concrete evidence before you're making recommendations, if at all possible. Sometimes we make it in the absence of evidence, but it's obviously a lot stronger if we can have evidence to support that. So we used to say that to these women. And what's happened is an explosion of information because of collaborations like the one that I mentioned to you that allow us to now tell these women that we can do things that are highly impactful. So Angelina Jolie very bravely wrote about what she went through, right, and what she did. And she went through surgeries to reduce her risk. And obviously what we're hoping is that women down the line won't need to go through surgeries and will have found something better to do to minimize risks and force them to go through rather aggressive surgeries to impact that. But what has also happened is that there has been an explosion of information in that field. So technology has kept pace. Medical knowledge caught up with BRCA1 and BRCA2, and all the while technology was going on the side. And initially what happened is that our genes were considered the property of one company. The Supreme Court said that's not okay, mercifully in 2013, so opened the door for competition for lots of companies to come in and offer genetic testing for hereditary breast and ovarian cancer. And at the same time, technology was evolving. So in the 1990s when I started, you could test for BRCA1, BRCA2. It took about 3 months to get the test result back. It cost several $1,000s. Where are we in 2017? Companies can now test for 10s, 20, 30, 40, 50, 60, 70 genes at a time, and you can get the test results back somewhere between about 2 weeks from now, or 2 weeks from the time you send it, to a couple of months to get that complete information. And what has happened is we've recognized there are other genes beyond BRCA1 and BRCA2, so that's what's being tested for. The asterisk on that is that our medical knowledge has not quite caught up with all of those genes. Okay? So while technology can test for these, we don't have data yet on the implications for all of these genes, either in terms of their cancer risks or in terms of what we can make recommendations for in terms of management for these women or these individuals. There are some that we definitely know about, but some that we don't. So I tend to tell people that technology for the time being has outpaced our medical knowledge. I'm quite confident that our medical knowledge will catch up, but I also tend to encourage women, if they're going to think about genetic testing, that they do that within the context of a program that has expertise in that, and that can help them figure out what the best test is for them, and to help them interpret those test results. So as I said, I was going to end by focusing a little bit on where I think we're going. And I think we're going in medicine increasingly towards this era of personalized or individualized or tailored treatment. And again, I think we're coming at that from a number of different ways. We have technologies that are available. We're frequently sending off individuals' tumors to look at what is expressed within the tumor itself. So the genes that are expressed, the ones that are silent, the proteins that are elevated and the ones that aren't, that hopefully help us identify things that could be targeted, that could be potentially the Achilles heel of that tumor. Sort of the analogy, the HER2 situation that I told you about, these drugs, Herceptin and pertuzumab, are drugs that hit the Achilles heel of HER2 positive breast cancer. What we're trying to find is the Achilles heel, not only of that subtype of breast cancer, cancers in general, but also we recognize that cancers are heterogeneous. So not every HER2 positive breast cancer is the same. There are differences between individuals. So we want to help do that. And I think technology is allowing us to interrogate those tumors, and we're also able to do it sometimes on blood specimens. So increasingly we're trying to look at the importance that we can gain by looking at maybe tumor DNA that is shed into the bloodstream, so people don't have to go through biopsies for us to get that. In conjunction and in parallel, there's tremendous advances in drug development. Okay? So we're seeing companies and basic scientists who are identifying drugs that could target these new things that are being identified. And so I think all of that is going to lead us to a much more personalized place. And then the final piece of this is really, how do we share this information? And I think increasingly what we're seeing is thinking about alternative methods, about web-based and other interventions to help educate patients, their families, others, on the implications and how to interpret and deal with these results, hopefully leading to either personal behaviors or lifestyle behaviors that would reduce cancer risk or reduce disease risk in general, as well as improve outcomes to therapy. So I'm going to stop here. I'd be happy to answer any questions, and thank you for your attention.